Okay, I think we'll get started. Good morning. I'm Jeff Miller, one of the co-directors of Grand Rounds with Kate Elkington and Christine Denny. We're delighted that you're joining us this morning. We have just a few announcements before we get started. The first is about planning for Grand Rounds for the coming academic year. We are seeking recommendations from everyone in the department about people who you would like to nominate as future speakers for Grand Rounds. And we're really seeking a diversity of speakers from multiple perspectives, diversity in topic areas, gender, underrepresented minorities. And we really would like to hear from you about who you think would be outstanding Grand Round speakers, both in terms of the quality of their work and as well, ideally someone who you have heard speak previously. And not only have they done interesting work, but they can speak about it in an interesting way. And so Simon will be posting a link in the chat to a survey. This link is going to stay live, hopefully in perpetuity. So we'd welcome you to click it, bookmark it, and at any time, please suggest some Grand Round speakers who you would like to hear. We will also, a departmental email will also go out with this link. And then in terms of today, we'd welcome questions for our Grand Round speaker at any point throughout the talk. So you don't need to wait till the end of the talk. You can post a question in the Q&A during, and we will get to those questions at the end of the talk during a conversation and Q&A session. Please don't post them in the chat, but rather in the separate Q&A feature at the bottom of the Zoom window. We will prioritize questions from trainees. And so if you're a trainee, please put the word trainee at the beginning of your question. And then the only other announcement is about next week's Grand Rounds. Next week's Grand Rounds will be given by Dr. Nolan Williams of Stanford University, whose talk will be entitled Stanford Accelerated Intelligent Neuromodulation Therapy. So this week's talk and next week's talk really have an interesting, consistent theme. They're both given by world-class California-based investigators at the forefront of neuromodulation treatments in psychiatry. And so that'll be a nice segue for me to introduce today's speaker, Dr. Katherine Scangos. Dr. Scangos received an MD, PhD at Johns Hopkins with her PhD in neuroscience, followed by psychiatry residency training at the University of California, Davis. She then moved to UCSF in 2017 for a fellowship in interventional psychiatry, and she joined their faculty in 2018, where she remains. And her area of interest is in developing novel therapies for neuropsychiatric conditions. She uses quantitative circuit-based neuroscience research to identify biomarkers of mood disorders and new forms of responsive brain stimulation therapies. And so this led to a clinical trial that we'll hear more about today of personalized closed loop deep brain stimulation for treatment-resistant depression. And in addition to her role at UCSF, where she co-directs the Transcranial Magnetic Stimulation and Neuromodulation Clinic, she's a medical director at Neumora Therapeutics. And her research has been broadly supported by foundation and government, from NIH, the 1907 Foundation, from which she received the Trailblazer Award, and BBRF/NARSAD. And there was also a lot of interest in the lay press about her work recently, both on NPR and then in the New York Times. There was an article in October about the work that we'll hear about today. The Times article was called "A Pacemaker for the Brain. No treatment helped her depression until this." So we're very excited to welcome Dr. Scangos to Columbia. The title of her talk is Personalized Deep Brain Stimulation for Treatment-Resistant Depression. Thank you, Dr. Scangos.
Thank you. Let me share my screen. All right, well, thank you very much for that kind introduction and the invitation also to present some of my recent work. It's unfortunate that we can't all be here in person. But as an overview, today I'll talk about the goal of personalization within depression treatments, the use of neuromodulation to specifically modify dysfunctional neural circuit activity, and then the clinical trial that we're running at UCSF, which is designed to test the feasibility of personalized closed-loop deep brain stimulation. So here are my disclosures. I've recently become affiliated with this company called Nomura. And here are the learning objectives. So first, state 3 approaches for personalized deep brain stimulation, understand the concept of closed loop control, and understand how spectral and network features can be integrated to identify individual depression subnetworks. So as everyone here knows, depression is a very common condition with a prevalence of about 300 million people worldwide. It's one of the leading causes of disability. And while many people can be managed very well with therapy or pharmacotherapy, there's a cohort of people who are resistant to all current standards of care. And this poor response rate may be due to the etiological and diagnostic heterogeneity of depression. Numerous studies suggest that depression can be related to alterations in a variety of different biological systems shown here. It's not likely to be one single disorder. And that's the idea behind the RDoC framework to investigate mental disorders that integrate levels of information and explore basic dimensions of functioning rather than the disorders themselves. So investigating anhedonia, dysphoria, cognitive dysfunction, et cetera. And new technologies like cortical or subcortical brain stimulation are focused on circuit dysfunction models of depression and are a potential solution for these patients who are resistant to available therapies, particularly because their symptom dimensions can be mapped to dysfunctional circuits and then specifically targeted. So intracranial brain stimulation, such as deep brain stimulation, has shown promise for the treatment of refractory depression. The way it works is in this treatment, a pulse generator is surgically placed either in the chest or in the skull and delivers stimulation through implanted electrodes in one area of the brain. And it typically targets single structures with fixed continuous stimulation. And it's been successful in Parkinson's disease and epilepsy, particularly. It emerged for depression in 2003, led by the pioneering work of Helen Mayberg. And in open label trials, patients, even with the most severe depression, achieved remission. And so there was a great deal of excitement because it was one of the first treatments that targeted specific brain circuits. Unfortunately, these results were not consistently replicated across 3 randomized controlled trials. And the figure here on the right shows the results from a trial of ventral capsule stimulation where efficacy was assessed at the 16-week time point. And you can see the lack of difference between the active and control conditions. And there's been a lot of talk about why this may be, whether that's due to the 16-week time point being in retrospect too early. However, inter-individual response heterogeneity also likely plays a large role. So rather than abandon DBS altogether, novel strategies in intracranial deep brain stimulation are clearly needed. So personalization of therapy as a means has been studied as a means to improve outcome in medicine generally. There's a lot of interest in this now. And the variable presentation of symptoms across individuals with depression suggests that different neural circuits may underlie different depression biotypes and speaks to the need for personalization of therapy in psychiatry as well. So here's an image from Leanne Williams' work where she highlights specific circuits underlying specific symptoms of depression and suggests that knowing the neural circuits involved for each patient might inform clinical decisions. So some patients might respond better to certain medications or treatments. And so personalization is likely also needed in deep brain stimulation. And in fact, shown here on the left, multiple anatomical stimulation targets have been identified and have shown promise in small studies. So these areas include the subgenual cingulate, ventral capsule, but now other regions within the reward circuitry, and the OFC as well. So the fact that stimulation at multiple sites can improve symptoms in different sets of people suggests that personalization and brain stimulation is also possible and may in fact be necessary. So I'll talk briefly of the two most common DBS targets. The majority of work has been done on the subgenual cingulate by Helen Mayberg, which really built on her cortical limbic dysregulation hypothesis of depression, where you think of depression as the net effect of failed network regulation, and that this can be modulated at different nodes within these pathways. And she identified subgenual cingulate as a key node that addressed what she perceived to be one of the core primary symptoms of depression, and that's dysphoria. And so her research found that there was increased blood flow in this region, in either induced sadness in healthy subjects or in depressed subjects, and that this overactivity decreased as depression resolved with successful treatment from antidepressants and also from DBS. And her work has also become more focused on personalization. So she's gone on to optimize targeting of the electrodes, identifying a particular region of the subgenual cingulate at the intersect of these three white matter pathways shown here. And she has shown that when you place the lead and deliver stimulation right at this intersect, it leads to the best outcome. The second target that's been most commonly utilized is the ventral capsule region. This is the part of the reward pathway and targets anhedonia, which is another key symptom of depression. And this region started out as a target for OCD with capsulotomy and then deep brain stimulation. And it was found to reduce depressive symptoms in those patients as well, and then moved on to be a target for depression in itself. And Samir Sheth's group is also working on a solution for deep personalization in DBS, and they implant leads in the ventral capsule and the subgenual cingulate, as well as temporary electrodes in additional brain regions. And the goal is to explore this large stimulation space. So they vary stimulation intensity, frequency, pulse width, polarity, and they use current steering to look at the volume of tissue activation and how it's affecting the broader network, so that once a patient begins DBS therapy, these parameters have already been personalized to the individual person. And so here's a comparison of three different trials, one that are going on currently, one from Helen Mayberg's group, where they're using tractography to personalize targeting, one from Samir Sheth's group, where they're using exploring this parameter space and implying additional leads to explore the circuit activation, and then one in our group where we're looking at both sensing and stimulation and trying to deliver closed loop stimulation. And that's what I'll describe now. Okay. So in deep brain stimulation, traditionally electrodes can only deliver stimulation, as I mentioned, but they can't sense neural activity. So the problem with this is there's no way to read out the effect that the stimulation has on the circuit that's being targeted. But it's also possible to implant microelectrode arrays or leads that can continuously record activity. And what's being shown here is a patient with spinal cord injury who has an array implanted in the motor cortex in M1 that senses neural activity. And when one particular pattern is observed, it can move this experimental arm shown here on the left, and then now more recently can move the patient's arm itself. So you can see from here that personalization of therapy includes not only where you stimulate in the brain or how you stimulate, but also when you stimulate. You know, you don't want this arm to be moving at any time. You want it to move just at the right time. And with motor system disorders, you have visual feedback, right? You see the arm moving, you see the tremors of Parkinson's disease may be reduced. But in depression, you can't necessarily visualize an emotion. or thought. You have to rely on subject or physician reports of their symptom severity state at each moment in time. But the same principles can apply. So with the addition of neural sensing, a patient's own physiological activity can selectively trigger stimulation when a pathologic state is detected. And you can read out the effect of stimulation had on the circuit you're targeting. So you have feedback, and that's the idea behind closed loop DBS. Treatment is delivered only when symptom severity is high, which reduces side effects, can prevent adaptation, and may improve efficacy. And there are a couple of devices that have the capability to continuously sense neural activity. This is a newer area. So I'm showing here in the picture the FDA approved and commercially available NeuroPace RNS system. It's used in epilepsy, and that's the one we're using as well. Medtronic also has a new device that can sense, that's being used clinically now for the first time. The biggest challenge, however, for delivering closed-loop deep brain stimulation in psychiatric disorders is finding this symptom-specific neural biomarker that triggers stimulation. And at the beginning of our trial, a biomarker like this had not previously been found for depression. So direct neural recordings and focal electrical stimulation have been used in the pre-surgical evaluation of patients with epilepsy in order to identify individuals' seizure foci before surgery. It's used to map out important functions that need to be spared, such as language or motor control. And these electrodes are implanted, either individual electrodes or surface grids, and they're left in place for about a week while patients remain in the hospital. And so we thought that a mapping stage like this would also be able to help us personalize for psychiatric disorders, deep brain stimulation for psychiatric disorders. And so now we have trials at UCSF for depression, which I'm talking about now, and also pain and OCD, chronic pain. And the idea is to extensively map the cortical limbic circuitry at the individual level, which means understand how stimulation affects someone in each part of this circuit, and then find a biomarker of a high symptom severity state that could be implemented into closed loop treatment with one of the chronic devices. And the ideas behind this goal were developed from years of research through a DARPA subnets program led by Eddie Chang at UCSF. And I came to UCSF as a fellow to work on this project and then stayed on as a faculty member to lead this depression trial. And in this research, motion circuitry was mapped out in patients with epilepsy to identify novel stimulation targets. And patients with epilepsy have a very high rate of depression. Biomarkers of anxiety and depression were able to be investigated because of this. So I'm showing here some of the work using intracranial recordings across 54 subjects to identify spectral activity and connectivity features that were predictive of depression. So this approach consists of two steps. One is a model building step, where we identified large-scale functional networks across these intracranial electrodes. And then the second step is a model utilization step, where we related the architecture and intrinsic neural activity of these functional networks to depression status, whether someone had depression or not. We further identified two clusters of subjects with depression that express different neurophysiological activity and connectivity patterns. And the idea here, these are shown here on the right on the bottom, is that being able to determine which of these clusters patients belong to could help you decide on a particular treatment. And we're now using non-invasive modalities to help identify correlates of these biotypes. And building on this work and other from the Subnuts project, we designed a clinical trial to test the potential efficacy and safety of personalized closed-loop neurostimulation for major depression. The goal was to perform this mapping stage in patients with primary depression and then implement closed-loop neurostimulation with the device I showed you earlier, the NeuroPace RNS system. And the trial is called the Presidio trial. So it consists of 3 stages. In the first stage, we implant 10 temporary 16 contact electrodes to map out the personalized stimulation and sensing targets and begin to identify a neural biomarker. And then in the second stage, the biomarker is integrated into closed loop therapy with the NeuroPace system. And then finally, in the third stage, we perform a randomized controlled study of initial efficacy and feasibility. So here's our study population. It focuses on patients with treatment-resistant depression. The major inclusion criteria to note here are two things that are a little bit different from prior studies. One is we require evidence that neural circuitry can be modulated as evidenced by a response to ECT, but not a sustained response. So these patients, show some improvement, but would really need to get ECT continuously to show a benefit, which is not feasible. And two, we need to see that there's sufficient variability in self-reported symptoms to enable biomarker detection. So we ask patients to take an iPad home and perform ratings over a period of time before they're enrolled to ensure that there's enough variability for biomarker detection. So here's the overall study trial design. Just to recap, the first stage of the trial is the implantation of the 10 temporary 16 contact electrodes. We do this across 10 different brain locations within the cortical limbic circuitry. And then over the course of 10 days, the patient stays in the hospital or laboratory setting, and we conduct stimulus response mapping each day to identify the targets where stimulation best improves the symptom severity. Then we also pair the resting state neural activity that we're continuously recording with clinical depression scales to identify spectral biomarkers of a high symptom burden. So if we're able to find a brain site where stimulation leads to a consistent change in clinical symptoms, then participants meet criteria to move on to stage 2. In the second stage shown here, the NeuroPace device is implanted with 2 4-contact leads placed in locations identified in the first stage. All those initial electrodes have already been removed. And then we have up to a year to validate the individual biomarkers and identify stimulation parameters that both modulate depression symptoms and shift the biomarker to a healthy state. And once subjects have achieved a 50% improvement on the MADRS or a year has passed, they qualify to move on to stage 3. And stage 3 is a core study period that looks at the short-term and long-term efficacy of the treatment. And it follows a crossover design with an intervening 6 months of treatment period. So the primary outcome that we're using is the MADRS score across the first and second 6-week crossover periods. So we've now completed stage 1 and 2 in 3 subjects and part of stage 3 in another. So in the set of slides I'm showing, I'll discuss the results from our pilot patient whose depression actually remitted with this closed loop treatment. So here I'm showing the results of the 10-day clinical mapping study for this patient. So during this time, as I mentioned, we performed bipolar stimulation across the electrodes in the ventral capsule, the subgenual cingulate, hippocampus, amygdala, and the OFC. And we saw really a large diversity of very specific responses across different sites and stimulation parameters. So we delivered about 90 seconds of stimulation, and then we asked the patient for her responses and what we observed as well. So some examples that I'm showing here are, oh, I feel tingles of pleasure with 100 hertz stimulation in the ventral capsule, or I feel neutral alertness, less cotton and cobwebs with 100 hertz stimulation in the subgenual cingulate. Another thing she said a couple times was, I feel this calm pleasure like reading a good book. Or another time she said, being wrapped in a warm cocoon with 1 hertz OFC stimulation. So I have to say it was very astonishing to see these effects. And we really could start to learn the roadmap to her brain, to the point where I could predict the resulting emotion or mood prior to the stimulation. And I think it was really an incredible experience for this patient as well, who had been really stuck in one state for so long, And for her to suddenly feel relief had really a big impact for her and her family, because it provided her with a sense of hope that her state could be changed. So after doing this type of stimulation where we're just asking for her response, we further explored the brain sites and stimulation parameters that elicited a positive response with sham-controlled stimulation. So here we're not telling her whether she's getting the stimulation or not and where the stimulation is. So we looked at the effect of stimulation using a couple of different clinical measures. We used a 5-point Likert scale that combined subjective responses with physician-rated affect. We used visual analog scales of depression, anxiety, and energy, and then a 6-question subscale of the HAM-D17 to assess short-term changes in depression severity. So the results from these scales suggested that stimulation largely modified the arousal and the mood valence dimensions in this patient. And 3 stimulation paradigms all reliably improved her mood. But they, interestingly, were associated with different effects on the level of activation. So 2 of the paradigms, 100 Hertz stimulation in the subgenual cingulate and the ventral capsule, were consistent with prior DBS studies. The third was a novel location and stimulation condition. This was low frequency stimulation across a broad region of the right OFC. So the responses to stimulation at these sites were consistent across trials. So the ventral capsule and the subgenual cingulate were consistently activating. The OFC was consistently sedating, and that's what's shown here in A. For example, the effect they had was consistent across trials, but the important part is that they had a different effect on mood depending on the current state. So for the OFC, the effect of stimulation was positive and calming if delivered during a high or neutral arousal state, but it worsened mood if delivered during a low arousal state, because then she felt excessively drowsy or uncomfortable. And then the opposite pattern was observed for the other 2 regions, subgenual cingulate and the ventral capsule, where stimulation increased arousal. So it was uncomfortably arousing, probably. So she felt anxious, and if it was delivered in a high arousal state. So we found that the effects of stimulation were state dependent. Her symptoms primarily were anhedonia. So she perceived the most consistent benefit from stimulation in one particular region of the ventral capsule, an area of the reward circuitry. So we pursued that area for her as the primary stimulation site. We also found that the response to stimulation was dose dependent, and that's what's shown here for the ventral capsule, for both the mood and arousal dimensions. We found that the response was sustained also beyond the stimulation period, and that's what's shown in these second graphs here. So even up to 40 minutes for the ventral capsule. So these were all findings that were important for us, right? The dose dependence, the persistence, and state dependence together suggested that closed loop stimulation may be a feasible treatment option that was worth further exploration. So this first part that I've described was to identify the stimulation target. So in addition to this clinical mapping, we also did biomarker exploration during this period. So to do that, we had patients perform 335 VAS scales of depression and anxiety over the 10 days where they were in the hospital. And we used these to define 2 symptom severity states, a low symptom severity state and a high symptom severity state, shown here in pink and blue. And we identified the 15 minutes of resting state intracranial activity, so the EEG activity, that coincided with these clinical measures where one of these 2 states was present. And then we found the spectral activity features that discriminated these high and low symptom states using 2 different cross-validated supervised machine learning models at different spatial resolutions. So in the first model, shown here on the top right, spectral power was averaged across all contacts within brain regions. So we had 60 total features. And we found that gamma power in the bilateral amygdala, right OFC, left subgenual cingulate, and hippocampus had high state discriminative potential. In the second model, the feature set was defined by spectral power for each electrode. And this allowed us to account for intraregional variability due to the electrode positioning. And here we found that bilateral amygdala power alone was sufficient for detecting the high symptom severity state, which surprised us that it could be something that simple. So together, the findings suggested that amygdala gamma power is a biomarker of the highly depressed state in this individual. So the next thing we did, so we found that the ventral capsule was the brain site where stimulation led to a consistent improvement symptoms. And the amygdala was the site of the biomarker activity. We next examined the connectivity across the cortical limbic network to determine whether these two regions constituted a structurally and functionally connected subnetwork, so that stimulation in the ventral capsule directly influenced the amygdala biomarker activity. And this could help provide additional justification for selection of these sites for placement of the chronic stimulation and sensing leads. So to do this, we looked at the effective network connectivity using EP mapping, evoked potential mapping. So in this, we delivered single pulses in one region and then looked at the evoked potential in a distant contact. And then we identified the N1 and N2 peak deflection magnitudes. These are just standard characteristics of the waveform using standard approaches. And I'm showing here in A, the directed graph for the N1 component. So the percent circumference here indicates the strength of the connection between any two brain regions, with the color indicating the starting location. So you can see the connections from the ventral capsule to the hippocampus, for example, here in orange. So then we quantified this connectivity strength and direction by calculating the weighted in degree, which is really just the weighted sum of the significant connections pointed toward a node. And then we also calculated out degree, which is the weighted sum of the connections pointing away from a node. And so we did this in order to identify the most influential hubs of the network. And we found that the ventral capsule had the highest weighted out degree. So this suggests that it has strong connections to other brain regions. And we found the amygdala and the hippocampus had the highest weighted in degree, suggesting that they received connections from many other brain regions. And this was consistent with what we would want for stimulation and sensing locations. You can also see that here projected on this brain with the strong amygdala evoke response to the ventral capsule, where here the warmer colors indicate the higher N1 deflection. So the last thing we did was to identify the structural connectivity. So we looked at the axonal fiber tracts that might mediate this effective connectivity using DTI. And we were aided by Leo Sugru, who's a collaborator of ours in the radiology department. And we found that there was also dense structural connectivity between the right ventral capsule and the amygdala, which was comprised of two fiber tracts, the stria terminalis and the ansa peduncularis. And then finally, shown here in this red and blue plot, we found that stimulation at the contacts 2, 3, which is the one where stimulation led to the best clinical improvement, improved her symptoms on 11 of the 14 trials. So when we looked at the change in gamma power on the trials where we had these pre and post VAS scales and resting state activity, we saw a reduction in amygdala gamma on both trials where symptom severity improved, and then it was absent when symptom severity worsened, which could be due to an alternate stim paradigm or remained steady due to minimal symptoms at baseline. So this is in line with what we anticipated. That's the ventral capsule and the amygdala not only are functionally and structurally connected, but we see an effect on the biomarker when we stimulate in the ventral capsule. So in the conclusions for this first stage are we characterized the complex interplay between symptoms, mood state, and neural stimulation. And we demonstrated the importance of a patient's symptom profile in interpreting the clinical response to stimulation. So these results suggest that the time a patient spends in a particular mood state should be a consideration in the selection of a stimulation target. And it suggests a biomarker can be identified and that we can identify a limbic subnetwork that both reflects depression severity and can be modulated to decrease symptom severity. And this is summarized. The approach we used is summarized here in this figure on the left. Identify stimulation sites, identify sensing sites, and then look at the effective network connectivity, structural network connectivity, and test the feasibility of closed loop by looking at the effect of stimulation on the biomarker. So this patient qualified to move on to stage 2. So here we implanted the NeuroPace device, sorry, with 2 separate leads, one in the sensing location and one in the stimulation location. And then we use DTI in the planning of the surgery so that the contacts interface with those 2 fiber tracts I mentioned earlier, the stria terminalis and the ansa peduncularis. And we were able to successfully replicate the location for those 2 sites. The second thing we did was to assess whether we could replicate the clinical effects of the ventral capsule stimulation that we saw in the previous stage. And so, as expected, we found that at the contacts that we predicted based on the anatomy, we again saw acute symptom improvement across the majority of trials. And she described this improvement again as pleasurable and energizing, just as she had in stage 1. And we saw the opposite effect when we stimulated in the amygdala. It made her symptoms worse. Furthermore, in closed loop stimulation, in addition to stimulation frequency and pulse width and current amplitude, which is what you need to traditionally modulate, we have to consider burst duration as well. So if this is closed loop, how often, when you do stimulate, how long will that stimulation be? So to do this, we tested the clinical effect of intermittent stimulation at different stimulation burst durations over 15 minutes and 30 minutes. And we found that just 6 seconds of intermittent stimulation at 1 milliamp was effective. And importantly, and this is something we paid a lot of attention to, it was below the patient's perceptual threshold. So this means that she couldn't detect on-off states because we didn't want her to go through the day feeling jolts of stimulation all day. So we wanted it to be undetectable. So we also found that we were able to replicate the biomarker for closed loop control. So to do this, we use the NeuroPace RNS system telemetry wand. This is a wand that patient can place over their head to stream the EEG activity in the lab. So we actually had her sit in the TMS chair and we recorded these 10-minute trials of continuous amygdala activity while she engaged in as naturalistic activities as we could recreate. These are things like looking at social media, talking to her family on the phone, watching movies, We even had her do her virtual therapy appointments while we streamed her activity. And we then paired this activity with her clinical severity ratings. And we again found that amygdala gamma power was correlated with both the VASD, the VAS depression scale, and the HAM-D6. And that's what's shown in this first plot. And it significantly differentiated the high symptom state from the low symptom severity state. After we did this, we implemented closed loop therapy so that 6 seconds of stimulation was delivered every time the biomarker was detected. And she went home with this on. And we found that the number of detections within the 10-minute period was also highly correlated with the VAS depression and HAM-D6 as well. So that's what's shown over here on the right. Number of gamma detections is correlated with the HAM-D6. So she went home, and over 2 months, we analyzed her data. On average, there were 468 detections per day, and she had minimal detections at night. We found that the stimulation did interfere with her sleep if it was given late at night. So we set a stimulation cap at 300 therapies per day and stopped the stimulation around 5 p.m. And so that's equivalent to about 30 minutes of total stimulation per day, which is, way less than standard DBS, which is delivering stimulation continuously, and is about equal to the amount of stimulation that you would get in a TMS treatment. And with this amount of stimulation alone, we saw a very rapid improvement in her symptom severity and depression. So her symptom severity measured by the VAS and her depression is measured by the MADRS. And of course, we can't say anything about efficacy with one patient, but observationally, her MADRS score dropped from a 33 the night before stimulation was turned on to a 14 at the first time this measure was collected 12 days later, and then dropped below 10, which is remission, several months later. And she actually remains in remission today, actually, and we implanted this in 2019 in that summer. And she's actually taking computer programming classes, engaged in her life, which it's pretty incredible. So to further test whether the closed loop algorithm triggered stimulation in a manner linked to the patient's symptoms and just not randomly, we examined the relationship between the morning symptom severity rating that she took and the daily detection counts over the 2 months. And so we used dynamic time warping to nonlinearly align the daily symptom severity and the biomarker detection counts that's shown here in the purple and gray. And so you can see here that they're pretty aligned. So we found that the fluctuation in daily symptoms was significantly associated with the fluctuation in the number of biomarker events detected by the device. So this suggests that the algorithm was able to detect change in symptom severity significantly better than chance. So in summary, we were able to replicate the effects of the mapping study with the NeuroPace device. The effects of the clinical response to ventral capsule stimulation was positive and energizing, and the amygdala power, gamma power was again found to be predictive of symptom severity state. And the patient's system appears to be operating in a closed loop manner linked to her symptoms. And this is a picture of her at home with the telemetry wand, recording her neural activity and then downloading it onto this laptop so we can view it remotely. So we have a lot of work left to do. We don't yet know how variable these findings will be across individuals, and whether the short-term responses that we're seeing will lead to long-term treatment of depression in everyone. It seems to be for her, but we don't know how long this will last. But these results are encouraging, I can tell you we did not implant in the same locations for the subsequent patients, but we were able to find clinical improvement in different regions and biomarker initial biomarkers in these subjects in different connected regions as well. So we don't yet know how those will hold up in terms of treating depression for the subsequent patients, but we're in the process of determining that. What's encouraging also is that framework is not unique to depression, but could be applied to a broad range of neuropsychiatric conditions like the chronic pain study that we're also performing, mood studies in Parkinson's disease as well as OCD. So the understanding of the circuit activity related to pathological states and the dose-effect relationship of circuit modulation that we observe can also add additional knowledge for other treatment development as well. And we would like to be able to, in the future, do this type of work with non-invasive treatments such as TMS and other upcoming treatments. A lot of times these relationships are studied in animal models, but it's hard in psychiatric disorders because the relationship is between circuit function and phenotype. Disease phenotype can be difficult to assess without, asking an animal how it's doing. So, one of our goals is to look for these human circuit biomarkers in these small patient numbers as we're doing to allow for back translation into animal models where more extensive testing of the circuits and stim responses can be performed, and then information from there can then be forward translated again into larger human populations. And really, it's the unprecedented access to the brain that can allow us to do so. And we're in the process of looking at these types of questions with a project that's ongoing with Stanford. So I just wanted to acknowledge all of the people who participated in this work and the tremendous multidisciplinary and collaborative team at UCSF, including Eddie Chang, who conceptualized a lot of the work and the DARPA Subnets project, Phil Starr, Ankit Kambadi, Ghassan Makul, and Andrew Crystal, who leads the broader brain stimulation program in the psychiatry department at UCSF. And then our other collaborators, Vikram Rao in neurology and Leo Sugru in neuroradiology, and of course, our funders as well. So I'm happy to take questions, and it's been great to talk with you all.
Thank you, Katherine. What a beautiful talk. Let's see. We have some trainee questions, but I also wanted to ask our chair if Dr. Lieberman, I don't know if you'd like to ask a first question.
Okay, well, that's a very nice talk, Katherine. Very, very detailed and exciting. And I have two quick questions. One is, the initial enthusiasm. I mean, psychiatry has been either blessed or cursed with not having lesion-based disorders like neurology. And, the initial area 25 versus any other area didn't pan out to be sort of the lesion that was the target for treatments, invasive treatments like this. Mm-hmm. Do you think that it'll be really individual, it'll be N of one type studies that need to be mapped by some electrophysiologic or imaging biomarker that'll define what the targets are, or that it'll ultimately be a localizable to one or just a small number of targets? And then the second question is, obviously, because of the invasive nature, this kind of treatment will be limited. What do you think the prospects are for less invasive and those that don't require craniotomies or and particularly focused ultrasound? Yeah.
Sure. So the first question about the location of the lesions or the stimulation. So I think, unfortunately, we don't yet know. My hope is that we will, for a while, do these N of 1 studies where we're looking at individual markers, but that by looking at all of these individual markers and targets, that we will end up with a few biotypes. So we'll have a group of people who require stimulation in subgenual cingulate and a group of people in the ventral capsule, and we'll be able to know ahead of time by imaging and by a thorough assessment of their symptoms. And then the personalization will just be where in those brain regions based on DTI or other assessments. So the goal would not be to do this intracranial mapping stage for every patient, but to do it just until we understand how the relationship between the circuits and the patient and different patient symptoms match up. So I think that will be for future research. And I think others agree. I mean, I know Samir Sheth's work, he also is doing this intracranial mapping stage in somewhat a similar manner. And he too views that as a temporary measure to gain understanding that will not need to be done long-term. We all are hoping to, move to non-invasive. Like you're saying, this treatment is only available for a small subset of very treatment-resistant patients who have tried all our other treatments. It is invasive. You have to undergo 2 different surgeries for this type of work. And it's, worth that for some patients who have, totally debilitated by their disease and at home and unable to work and engage in their relationships. But that's certainly not the case for the vast majority of people suffering with depression. So, I am encouraged by these non-invasive techniques. We do TMS in clinically. That's what I do for my clinical work. And we try to do localization, and you'll hear more about this from Nolan Williams next week. We do have ways to localize and use patients' MRI machines, but it's just not focal enough, and it can't reach deep structures. So it's unclear how valuable it will be for some patients who require stimulation in deeper structures. But certainly, I think we can learn a lot from this type of work and understand which patients and can be targeted with cortical stimulation and, where ahead of time. So we don't spend, 5 weeks stimulating in the wrong place for certain patients. Focused ultrasound, I think, is very exciting area, and UCSF has written some grants and is trying to work towards pursuing some of that research. I think, we don't know how well it will work, but I think it's a really encouraging area that I'm certainly excited about.
Great. I'm going to shift to some trainee questions. One trainee asked, can you talk about the sex differences in the DBS targeting? Are different regions being targeted to improve outcome between sexes, or more so the frequency protocol of stimulation? And I know these are early days, but do you have thoughts about that?
Yeah. I think that's a really interesting question. I don't know the answer to it. I don't think anyone's looked at, in part because the populations haven't been large enough to really do a thorough analysis of that question. But there may very well be differences in sort of depression type between sexes that could respond better to certain brain areas than others. I would expect that it may be more due to a patient experience and patient sort of the historical life story of their depression that leads to certain circuit dysfunctions, along with, of course, genetics and everything, more than sex. So I think it's always hard to untangle that question, however.
Great. And then another trainee, Evan Lieberman, said, this overlaps a little bit with Dr. Jeff Lieberman's question, but I think we can expand it a bit. He said, if the efficacy of this treatment strategy is borne out in randomized clinical trials, what do you expect the scalability will be to the many patients with treatment-resistant depression, given how resource intense, time, cost invasiveness it appears? And another person asked what the treatment cost. And I guess just if I can sort of editorialize a little bit, your early slide spoke about the prevalence of depression and the great disability that, it is one of the leading causes of disability globally in the world, depression. And so I wonder, are we jumping the gun to think that, a surgical approach can't be implemented in a widespread way, given how disabling this condition is and how surgery is a common treatment for other medical conditions that may be not even as disabling?
Mhm. Yeah. So yeah, depression can be really disabling, like you said, and it may always be a subset of patients who would benefit from this type of surgical treatment. In the same way of Parkinson's disease, right? There's a subset of people who receive DBS. It's not the majority of patients with Parkinson's disease, but there are a group of people who, once they no longer respond to dopaminergic medications, can respond well to something like this. So I think we may see something similar in psychiatry. It will definitely likely be a minority of patients who require a surgical intervention, but it could be really life-saving for that smaller subset. I think what will be most helpful from this type of research is the knowledge that we gain. It's really, we don't have access to these circuits in the way that we do, and we haven't ever before had this type of access. So we can really explore the relationships between specific neural circuits and the symptom profile that's where stimulation across these nodes results from. And I think that understanding is very valuable. And so we can understand, which are the circuits involved in symptom types, how quickly people can respond, the dose response relationships. And that likely, as I was mentioning towards the end, won't all be done in patients. It will likely, we'll gain some information and then explore it more thoroughly in animal models, so we can, really understand the relationship between one stimulation parameter and the effect on the circuit really thoroughly. But we'll gain enough information and understanding about that relationship in these human subjects. So I think that will end up being most helpful. And then, I think we will have the potential to translate some of these biomarkers to non-invasive modalities. So if we understand this amygdala biomarker in this patient, and maybe there'll be a couple groups of biomarkers across populations, is there an EEG correlate, an imaging correlate? Can we use a multimodality approach to capture sort of a correlate of this deep biomarker? And I think that is also likely possible. So we may be able to learn about patient biotyping with non-invasive tools based on some of this work, not just what we're doing, but others in the field, Helen and Samir Shath, and frankly, across neurological disorders as well, because we're starting to gain a lot more information with the ability to record and activity with these now clinical devices, which has just started recently.
Great. And then a question from Ralph Wharton, which is, I think, asking for more details about like the effects of the intervention on the brain. Is your treatment changing circuitry, neurochemistry, neurohormonal or electrical patterning? Is the implication a potential for long-term, or too soon to say?
Yeah. So, some of the answers to those questions we don't yet know. I really have results in one patient and very preliminary results in the other patients. So we don't know, but there are a lot of interesting questions. So we would hope that this would be a long-term type of treatment. And this patient has, received treatment for a while now, and she's doing very well. Of course, we don't know whether that will hold true for others. However, one of the interesting question is, will the biomarker remain the same, across time, or will you target one biomarker and sort of lead to resolution there, and then, need to shift to treating another circuit or not, and, encompassed by a different biomarker, and the evolution of that over time. And so we actually thought we'd need to make some changes along the way, more than we have so far in this initial patient. It seemed pretty constant. But we're still in the process of understanding the longitudinal effects, and we don't know the effects on brain chemistry or hormones yet. Although, we had some plans to collect that information, but then we didn't end up because there's just so much data. We did collect also like Fitbit and some of these other physiological measures that we didn't analyze yet as well. So we may have answers to those questions soon.
Great. A question that I had, I noticed it was an important point you made about the eligibility criteria, that you were looking for people who had variability in their symptoms, right? And because my understanding is that to develop the biomarker, you're looking for changes in the states of the depression severity over time within a single subject, right? The biomarker is truly N of 1. It's not about how this person's brain differs from people without depression's brains. It's how this person's brain varies as a function of their depression severity, if I understood correctly. So it seems to me like an implication is that it would be, this intervention might work more for people with sort of like classically thought of as atypical depression, right? That can have some mood reactivity. There's fluctuation in their mood, as opposed to someone, these are older concepts, but with more like of a melancholic type of depression where there's less fluctuation in their mood reactivity. Do you have a sense of, do you think about it in those ways? And will there be people with treatment-resistant depression whose mood is really flat and down monotonously, who wouldn't be good candidates for this type of an approach?
Yeah, so I think that's exactly right. In order to identify a biomarker, you have to have two states. You have to understand the neural activity related to one state and related to the other state. And so you can't really run the algorithms if you don't have that data, because you don't know, you just can't do it mathematically. So we required there to be some variability, which, exactly like you're saying, may select for patients with more mood reactivity. It does, for sure, selects with patients with more mood reactivity. And I think for now, we will need to keep selecting those patients as we search for individual markers. We hope that long-term we won't. This gets back to what I was talking about before, is that we may gain information that there are a couple common biomarkers across patients, and be able to select out one of those biomarkers just based on a patient's anatomy or symptoms that ends up being effective for that type of patients. But I think that will need to be an experiment in itself of whether that holds true or not. And so for now, we rely on this type of patient if we're doing closed loop control. I think, other people may respond better to either just intermittent stimulation or continuous stimulation or timed stimulation. So they may need to receive a different type of deep brain stimulation. Helen Mayberg's patients tend to, have a more melancholic depression. And although she doesn't recruit for that, she's just described anecdotally that her patients tend to end up having those symptom characteristics. So there may be these differences between the trials as well.
Dr. Lieberman asked about whether you're planning or envisioning an RCT, a controlled trial with sham intervention.
Yeah, so when we do a lot of sham stimulation in the 10-day period, so during the time when we're looking at the response to stimulation, that's all sham control. The patient doesn't know when they're getting stimulated or whether they're being stimulated or not. And interestingly, during sham stimulation, patients report a lot of somatic symptoms, like they'll say, oh, my head, my scar, my incision hurts, or my stomach hurts, because they're really trying to answer how they're feeling. And then when the stimulation's on, they respond more with features related to their depression, and that's held up across the subjects. Once we are in stage 3, that's when we do the 6-week on-off periods. And so that's also sham controlled in that sense. So patients have 6 weeks on, 6 weeks off, but they don't know which they're receiving. And so that happens at the beginning of the year and at the end of the year. And so we've done that for our first patient. We haven't done the second period, so I don't want to say the full results of that, just because some people are still blinded to the treatment. But we are doing that, and that's an important part of the trial.
That was kind of an unfair question, which I think you answered very, very, very well. And it was prompted by a couple of things. One is, when psychosurgery was first developed and the prefrontal leucotomies. When they came to the United States, this neurologist that popularized the treatment, Walter Friedman, was frustrated by the limiting factor of neurosurgeon and anesthesiologist being required, and developed the transsphenoidal approach, which obviously worked out disastrously. So, we need to be very careful in terms of how we pursue the investigation of this treatment and verification of its efficacy. So that'll be a question that you get to when you're able to proceed with a methodology that is able to be FDA approved and reimbursable by companies, et cetera.
There's a huge placebo response as well that you have to watch out for, right? Because these patients are really desperate for treatment, and you have such a relationship with them for so long, an intense relationship. So I think that needs to.
And I can recall that when dopamine cell grafts were being used for the treatment of Parkinson's disease prior to the DBS, they actually did do the sham surgeries where they did craniotomies as part of it, but obviously that's a pretty invasive step to take. Just one other thing, which also is a little bit in the provocative realm. Andres Lozano at the University of Toronto has kind of been a pioneer in this area and has applied deep brain stimulation approaches to a wide range of disorders that beyond what one might have thought would be most amenable to it. What's your sense, and what's Andy's sense of that work?
Yeah, so I think he's looked at some other disorders like Alzheimer's disease, for example. And it's interesting to think about how many disorders could this work for, and especially in degenerative diseases where you may be stimulating tissue that's not healthy, and can you restore function to a circuit that's not functioning well because there's tissue loss or damage to the structure. So I think that's not known right now. I think we do have to be careful about applying surgical lesions everywhere for every disorder. I think this type of treatment works best when there's a clear circuit dysfunction, and we understand pretty well that there's dysfunction in this circuit and this circuit and this circuit, and we can target those circuits specifically. I think that's true for many neurological and psychiatric disorders right now, but definitely not all.
Katherine, I had a question about the timing of the stimulation, right? And when I understood that the approach was really state-based, right? That the biomarker is learned and the stimulation is applied when the biomarker indicates that the person is in a worse depression state. It made me think about an analogy to PCA, patient-controlled analgesia, right? After surgery, where patients have control with a button of when opioid pain medication is given, and they press the button when their pain worsens. I mean, the frequency, I think, how many, it's many stimulations a day that are given, so maybe it's not so feasible, but have you ever thought about ideas like that rather than using a biomarker, a patient would have control over when the stimulation was administered?
Yeah, I think, we've thought about that. I think that brings up its own ethical considerations as well.
Sure.
Whether stimulation is addictive, or what's causing someone to seek stimulation at that time. So we are trying to sort of avoid that by stimulating when patients are not aware of it. So we don't really want the patient to know they're getting stimulation and aware of the stimulation. We want it to be sort of sub-threshold. They go through their day, they don't know when they're being stimulated or not, because I think that's also more healthy for a patient as they try to engage in their normal life and practices. This patient said that when she receives stimulation, she feels like it improves her cognitive, like it turns on her thinking part of her brain rather than her feeling part of the brain. So she's able to rationalize a situation better, and it stops her sort of from that ruminative cycle. So she thinks she knows sometimes when she's being stimulated, but she definitely can't feel it going off. Yeah, so that's an interesting question. A lot of times patients don't want that control. I think there have been some studies in Parkinson's disease also, and some patients sort of just want it to be going off and not have to think about it or deal with it at all.
Great. Well, this was really a rich discussion. Thank you so much, Katherine. We're really grateful for a beautiful talk, and we look forward to seeing where this research leads over time.
Thank you. I really appreciate being here and all the really great questions that people asked.
Great. Thanks, everyone. Have a great day.
Bye.